Thanks, Marion. I'm going to be presenting this on behalf of my co-author, James Bamber, and the other contributors to this chat. I'm sure we've all seen this figure today already, and reassuringly, you can see that there was anaesthesia is right at the bottom of this list of causes of maternal mortality. And in fact, there was a single anaesthetic death in the period covered by this report. I do think it's important to remember that deaths from anaesthesia really represent iatrogenic deaths. Anaesthesia is not a disease process as such. The other causes on this death are all pathological processes, but I think it's important to keep that at the back of our minds. Now, before I present the findings related to anaesthesia, I just wanted to very briefly present the findings of another ongoing national study that helps provide some context to obstetric anaesthesia in the UK. So this figure comes from the 7th National Audit Project of the Royal College of Anaesthetists. The National Audit Projects investigate rare problems in anaesthesia, and the topic of the most recent investigation is perioperative cardiac arrest. Now, with every audit project, an activity survey is undertaken to provide denominator data for the project and also to chart anaesthetic activity. Now, here you can see that in terms of workload for the anaesthetist during the daytime, elective orthopedics is the single biggest area where anaesthetists work. But once you get to the evenings and night times, this is really overtaken in a huge way by obstetric anaesthesia services. And out of hours, obstetric anaesthesia services account for about 70% of all anaesthetic activity in the UK. The activity survey for the 7th National Audit Project estimated in the period covered about 350,000 births, anaesthetic interventions in obstetric patients. And the number of live births in the same period was almost 700,000. So this means that anaesthetists are involved in around about 50% of births in the UK. Now, this point particularly relates to this figure here. Now, this is, again, I'm sure everyone's seen this figure already today, and it describes the quality of care received by the women who died in this period. And just over 50% could have received better care, improvements to care, which may have made a difference to outcome. Now, if anaesthetists are coming into contact with 50% of women who give birth in the UK, it's likely that sometimes our care could, while not causing the maternal death, could have been better and may have contributed to the overall outcome. So I'm going to discuss circumstances around maternal death and then a selection of other topics, which there may be some overlap with what's already been discussed today or what we will be discussing, but I've tried to pick things out that we may not have covered, but I apologise if there is any overlap. So the maternal death, one woman died in association with obstetric anaesthesia with obviously a very low rate. This was a complicated birth. It occurred after the onset, the death occurred after the onset of bilateral tension pneumothoraces, the cause of which was unknown. Spontaneous pneumothorax in pregnancy and intraoperative pneumothorax are both very rare. Risk factors include insertion of central lines or trauma to the tracheobronchial tree. In terms of learning for anaesthetic practice, I think learning rather than recommendations. I think we always are, but we must continue to be meticulous in being alert to the inward migration of an ET tube, because if it goes down too far into the right lung, it can increase airway pressures. And this is a particular concern at intubation when we first pass the tube, or movement of the tube when a patient is transferred from the bed to the operating table. And I think the second point to note is that when a woman collapses, it's really important that we systematically evaluate all possible causes of cardiac arrest to help ensure that reversible causes are recognised and treated promptly. We're always very mindful of the more common causes in the obstetric patient, for example, most obviously hemorrhage, but we mustn't forget about the rarer causes which may be reversible. Now, let's move on and talk about management of neurological emergencies. A woman with mild thrombocytopenia and abnormal LFTs received syntrophin and diclofenac after a vaginal birth. Shortly after delivery, she developed neurological signs and had a rapid reduction in her Glasgow Coma Scale score. She was transferred for a CT, which showed evidence of intracranial hemorrhage. She was only intubated after this point with a hypnotic agent, so an agent that we just used to put the patient to sleep, and a muscle relaxant to help intubate the patient. She was then transferred to the neurosurgical unit where she unfortunately died. Now, anaesthetists do have national guidance, not just related to obstetrics, but all neurological patients about how we should care for these patients. And in any patient with a deteriorating conscious level, where the airway may be compromised, they really should be intubated before proceeding to CT scan. And I think the other point about this patient is that she didn't receive any drug that might obtund, that might reduce the high blood pressure rise you can see when patient is intubated. And it's very important that we don't just think about how we treat the obstetric patient. We don't always use opioids in obstetric patients during intubation, which is not something I agree with, but it remains a reasonably common practice. But we mustn't get into an obstetric silo. We must think about the holistic patient. This patient wasn't so much an obstetric patient as a patient with neurological disease. So a couple of vignettes about obstetric hemorrhage, which remains a very important cause of mortality and morbidity. A woman had a 1.5 litre blood loss after vaginal delivery and went to theatre. She was tachycardic and hypotensive. She had a GA and her hypertension was managed with an increased rate of vasopressors, drugs to put your blood pressure up. She didn't receive a transfusion until more than an hour after the start of the hemorrhage, by which time the blood loss had increased significantly. She did have a 2-unit transfusion, but unfortunately had a cardiac arrest and couldn't be resuscitated. Another one, a woman had a hysterectomy after a hemorrhage. She had an estimated blood loss of more than 50% of her circulating blood volume, and she was hypotensive, tachycardic and acidotic, and a noradrenaline infusion was started and given at increasing rates. Fluid resuscitation was limited and included unwarmed fluids. Blood was administered late. She unfortunately had a cardiac arrest in the ICU and could not be resuscitated. So in terms of new recommendation, updated guidance is urgently needed on the use of coagulation tests in the context of obstetric hemorrhage, including the timelines for availability and how to interpret these. Noting particularly that women should not be inappropriately denied clotting products based on a single measure of coagulation in the face of ongoing hemorrhage. And I think updated, we've got very minimal guidance, in fact, but any guidance that might support management of coagulation products would be incredibly useful for all of us. There's a number of other existing recommendations that it's worthwhile reiterating. In many of the cases that were reviewed, the excessive use of vasopressors in the context of obstetric hemorrhage was noted. Anaesthetists are very familiar with phenylephrine infusions. We have them for every caesarean section these days. But in the context of hemorrhage, they should only be used in conjunction with fluid resuscitation, ideally warmed fluids, blood, colloids, crystalloids, whatever you choose to use. Ideally, these fluids should be warmed. And this is really important to try and maintain normothermia, to try and minimize the risk of coagulopathy developing. Clotting products are proteins. You're not going to get an egg to boil in cold water, so it's really essential we try and maintain normothermia. And high volume resuscitation with crystalloids and colloids is associated with coagulopathy. So we've really got to get that balance right between crystalloids and blood products. A couple of other existing recommendations. When bleeding starts, it's important to get a seniors team there early on. The experience can be invaluable to try and support the management of a PPH. This isn't something the registrar should be managing alone. We should be doing multi-professional training, and it should include rehearsals for situations such as MOH. And something that I always think possibly the consultant anaesthetist may be best placed to do is to take that helicopter view of the management of a woman with major obstetric hemorrhage, just to make sure that we're not forgetting any particular aspect of the care. Before I move on from hemorrhage, just a couple of other things. This report did highlight some particular areas to focus on in multidisciplinary training in obstetric hemorrhage. We've got to be meticulous about important, knowing that we can recognise and estimate blood loss. We've all seen situations of blood loss where the blood loss has been absolutely torrential, but we've also all been in situations where we're not totally sure whether a woman's bleeding or not. So we've got to really use everything we can and make sure every member of the team is confident about recognizing blood loss. And this may be, you know, getting other people involved, asking for help. You know, we all live with clinical uncertainty, and there is absolutely no shame in saying to anyone, regardless of how senior or junior you are, I'm not sure about this. What do you think? And I think the other point to emphasize is that we mustn't rely on a single point of care test, you know, single HemoQ, a single blood gas. It's trends which are as important as a single assessment. And the very final point to note is that these situations, regardless of whether a patient dies or not, can be incredibly traumatic for staff. We must ensure that staff get support after managing these situations. Now, the next one, organisation of caesarean birth. This isn't specifically an anaesthetic issue, although I think it causes anaesthetists quite a lot of stress on a day-to-day basis, likely obstetricians and midwives too. But I think it's important that we talk about this problem. A woman received a spinal anaesthetic for a Cat3 section that was delayed until the evening because of capacity issues. Following delivery, she had a massive hemorrhage. There was delay in coagulation products being issued. She had a cardiac arrest and couldn't be resuscitated. So the recommendations here, we do need updated guidance, national guidance, to make certain that category 4, and I would suggest category 3 caesarean sectionists are managed separately from more urgent caesarean sections to ensure these operations are not delayed to late in the day. Lots of people have made this point, but in terms of how elective obstetric services are organised, this is completely different to orthopaedic surgery, elective orthopaedics or elective gynae, which has very definite separate facilities, whereas in many units elective caesarean sections are just carried out amongst the emergency caesarean sections, and this inequity of care is really unacceptable. As perhaps a slightly self-evident but important recommendation from previous reports, all units are required to have escalations for periods of high activity, and this should be about getting more staff across the board. And of course, this is incredibly difficult. We barely have enough staff on a day-to-day basis. But Don Rockenden also made this recommendation about having clear escalation policies. And I think it's something we all need to think about, how we're going to manage this in the very constrained environments we all need working. Another vignette about placenta previa and post-op care. A woman in her 40s had a massive PPH following a second caesarean section for previa. During the caesarean, the consultant obstetrician cut through the placenta to deliver the baby, and the placenta was delivered piecemeal. A Bactri balloon was placed, and she received uterotonics and vasopressors. However, 15 minutes after transfer to the delivery unit for post-op care, she became unresponsive and appeared to have a seizure, which is likely a pseudo-seizure related to hypotension. She was transferred back to the theatre for a hysterectomy. Post-op, there was limited space in the ICU, which meant that she remained on the labour ward until her discharge 4 days later. So the recommendations here, we need to review and revise the specific service specification for centres that provide specialist care to women who have an abnormally invasive placenta, to ensure that they can really provide the full range of care that's going to be needed, including adequate post-operative care. And I think more specifically for anaesthetists, for these women who do have significant bleeds, significant comorbidity at the time of delivery, they really need post-operative care in a specialised recovery area, whether it's an HDU or going to the ITU. Now, this point about clinical vigilance and diagnosis was something that was noted by many of the assessors in many of the cases. 2 vignettes. A multiparous woman had an induction of labour following a preterm IUD. Shortly after induction, she became tachycardic and had an increased respiratory rate with a normal blood pressure. She had some IV fluids, but 6 hours later, she was again noted to be tachycardic, up to 150 now, with a systolic of less than 100. She had further IV fluids, but no senior medical review. The tachycardia settled, but she was increasingly restless, which was attributed to labour progress, and no further action was taken. 2 hours later, while in consultation with the anaesthetist regarding labour analgesia, she collapsed and became unresponsive, and a perimortem section revealed a ruptured uterus. Another woman had a caesarean birth, after which she became tachycardic and hypotensive. She was reviewed twice by the same clinician, who prescribed some IV fluids and asked for a full blood count. The tachycardia did settle, but she continued to have hypotensive episodes, which the doctor suggested was in the acceptable range. There were no further investigations. This woman had a cardiac arrest 3 hours after hospital discharge due to cardiac tamponade. And I think both of these cases demonstrate the theme that I mentioned, a lack of clinical vigilance and diagnostic curiosity. The doctor who reviewed the second woman did so twice, but didn't formulate a differential diagnosis or request further investigation, such as lactate or blood cultures. And there were several women throughout the reviews where assessors felt the care could have been improved by more vigilance and diagnostic curiosity across the whole team. And I think in the presence of persistently abnormal physiology, no diagnosis is not an acceptable path to tread. A doctor really should formulate a diagnosis with a differential and use advisable diagnostic tools to try and support a diagnosis. But I think the big thing for me here, and I would really emphasize this regardless of somebody's background, whether you're a midwife, obstetrician or anaesthetist, is that, and regardless of your seniority, is that if you're uncertain, you should always ask for a second opinion. We all live with incredible clinical uncertainty. It's not always obvious what the diagnosis is. And talking it through with another clinician, somebody who can just provide another perspective, it can be incredibly useful. And this should be for everyone. We should encourage this culture across seniority and disciplines. So the very final point I just want to mention is the issue about electronic records, which are, if you haven't got them, they're coming to a unit near you soon. Case review did identify that there were deficiencies in the design and interface of electronic records, which created barriers to accessing and assessing information during emergencies. Unfortunately, the NHS doesn't have a standard universal EPR. We all seem to use different ones. Issues noted included the visibility of warning signs and red flags, difficult to recognise and took too long to find. And in some systems, something I think was particularly worrying is the EPR displayed measures, cardiovascular variables, which were taken at booking rather than current findings, which led to misinterpretation in emergencies. So these will definitely be coming, and I think it's really important that we're aware of their limitations and try and create strategies to manage these. So I hope I've provided something of an overview, something that's useful to anaesthetists and to other colleagues who are listening in today. Thank you.